We're going to have only one lecture on antiviral drugs. My reference is the pharmacology textbook. The medical letter, a relatively old reference, but it's useful because it has the classical drugs, since we will only mention the classical drugs. Why are viruses so hard to treat? Well, because one, they are quite heterogeneous agents. Each one of them behaves differently. And also, they replicate intracellularly, so the drug has to go inside the cell. And they use host cell machinery. They use us. So we really have to exploit differences for drug development. This slide shows the outline that we're going to use in this lecture. We're going to pretend that the circle is the host cell, and then you can see the virus binding to the receptor, attaching and entering, uncoating, genome replication, followed by protein synthesis, assembly and maturation, and finally egression and release. Of course, here I'm mixing several antivirals that are given for different types of viruses. Each virus has a different cycle, but for the sake of the outline, we're putting them together. So we're going to start with the CCR5 co-receptor inhibitor, Maraviroc. This is actually given for HIV. Then we'll move to fusion inhibitor and Fuvirtide. This is also for HIV. Ion channel blockers, amantadine and rimantadine. This is for influenza A, although now the first line for influenza A are neuraminidase inhibitors, basically oseltamivir. Then we're going to move to different types of polymerase inhibitors. We have DNA inhibitors, reverse transcriptase inhibitors, and RNA polymerase inhibitors. And the ones listed here are the reverse transcriptase inhibitors, the antiviral, anti-HIV. Then we'll move to integrase inhibitors, also for HIV, protease inhibitors, also for HIV, and finally neuraminidase inhibitors. This is just to remind ourselves of the HIV life cycle. Why? Because we're going to see a lot of drugs given for HIV. So we start with binding of the virus on using the GP120 and GP41, and we're going to need the CD4 and the CCR5 on the host, and then we'll have fusion, we'll have reverse transcription, and we have integration as well, integration of the viral DNA into the host DNA, followed by transcription, translation, assembly, and then it will go out and we'll have maturation. I highly recommend that you watch this short YouTube. It shows us the virus, the HIV cycle, followed by the drugs that we use to treat the virus, and it's kind of really nice. Okay, let's get started. The first one is CCR5 co-receptor inhibitor, Maraviroc. It's a very interesting drug, and we have only one slide. Remember, we're only having one lecture for antivirals, so we're going to go over them really quickly. It's a PO drug, and why do I write that it's a per-os drug, oral drug? It's important because you already know that the treatment of HIV is a chronic treatment. You would have to take drugs for a long time, maybe forever, and it's kind of cool to have it as PO in contrast to some subcutaneous therapies that we will see later. This can be used for treatment naive and experienced patients. What I mean by naive, it can be the first drug to be used. Experienced patients, those are patients who took other drugs and now it's not working anymore. We have resistance and we have to choose something else. Common side effects are pyrexia or fever, rash, cough, musculoskeletal symptoms, abdominal pain, and postural dizziness. And there are some CYP drug-drug interactions. It's important to keep the CYP drug-drug interactions in mind because several of the antiretrovirals are actually also associated with CYP drug-drug interactions. And you probably already know that many times we combine those drugs, so you'd have even more drug-drug interactions. And since those drugs are given for a long time and maybe forever, so patients might need to take other drugs. Maybe they develop tuberculosis, maybe they need to take rifampin, and you already know that there are drug-drug interactions in this case. Maybe they develop diabetes, they develop hyperlipidemia, and they need drugs that may also interact. So this is problematic.
Another relatively new drug, an attachment inhibitor, is the GP120 attachment inhibitor, fostemsavir. The active metabolite of fostemsavir is actually temsavir. It's a PO drug. And how does it work? As we've seen in the YouTube movie, in this case, it binds to the GP120 subunit, and this inhibits the viral interaction with the host CD4 receptors and hence preventing attachment. And this is another drug that blocks entry of the virus after attachment. So it already attached using CCR5, for instance, but then it cannot enter because of CD4 inhibition. This is a monoclonal antibody, and we already talked about that, and probably you can guess from the name, it finishes with MAB. Adverse effects to be expected: local injection site reactions, systemic hypersensitivity reactions, and we also can have cold or flu-like symptoms.
We're done. Next is the fusion inhibitor and enfuvirtide T20. This is a GP41 inhibitor. It's given subcutaneously. It's not for treatment-naive patients. We keep it for treatment-experienced patients with ongoing HIV replication despite current antiretroviral use. We do have some adverse effects such as local injection site reactions, eosinophilia, and systemic hypersensitivity reactions.
Next, we move to inhibition of viral uncoating. In this case, it is amantadine and rimantadine. These drugs are not antivirals. They are actually for influenza. And note that they are no more first line for influenza. Now, the first line treatment for influenza are the neuraminidase inhibitors that we will discuss later in this PowerPoint presentation. The mechanism is again inhibition of viral uncoating. You can have a look at this figure, and then everything is written in words on the slide that comes next. Basically, what those drugs do, amantadine or rimantadine, they inhibit the M2 channel, and hence we no more have acidification inside the virus, and hence this will not let the dissociation of the matrix protein occur, and hence we will not be able to have RNP release from the endosomes. And as promised, those are the words written here showing how amantadine and rimantadine work.
So I mentioned that those were used for influenza A. When do we use amantadine? When do we use rimantadine? Amantadine is associated with CNS toxicity, central nervous system. A patient might have lightheadedness or difficulty concentration, and hence we do not give this to people who are old. For elderly, we keep rimantadine, and we give them for prophylaxis because elderly may be living in nursing homes, for example. If you have an outbreak and you want to prevent spread of the disease, you may give prophylaxis for elderly, rimantadine specifically because less CNS toxicity. We're done with those. Now we move to inhibition of viral genome replication. And here we're talking about inhibiting DNA polymerase, RNA polymerase, and reverse transcriptase. One way to do it is to have nucleoside analogs that would compete with the nucleosides on the polymerases or the reverse transcriptase. I just want to remind you that a nucleoside has to be phosphorylated 3 times by a first kinase, a second kinase, and a third kinase. So we have the nucleoside triphosphate or the nucleotide, and this is the one that competitively inhibits the growing DNA or RNA chain. And this will come up in a few slides from now. Why is this important? In this slide, I show you the outline that we're going to follow in the coming slides. First, we're going to start with the anti-HSV and CMV herpes simplex virus, cytomegalovirus, and also, by the way, the varicella zoster virus. We will start with the nucleoside analogs. So again, those are analogs to specific nucleosides and hence will inhibit the DNA polymerase in this case. I'm going to talk about acyclovir and the prodrug valacyclovir, and then ganciclovir and the prodrug valganciclovir. Then we'll move to the nucleoside analogs that are for the retroviruses, and we call them NRTI. This is important nomenclature. NRTI, nucleoside reverse transcriptase inhibitor. We're going to discuss several, all of which are nucleosides except for the last one, tenofovir disoproxyl fumarate, TDF, which is a nucleotide analog. Then we will move to inhibitors of DNA polymerase in the case of HSV and CMV, and reverse transcriptase in the case of HIV, but that are non-nucleosides. So they inhibit the polymerase but without being of a structure that looks like a nucleoside. So we will discuss the non-nucleoside DNA polymerase inhibitor. In this case, it is foscarnet. And for the HIV, it is NNRTI, non-nucleoside reverse transcriptase inhibitor. And the prototype drug that we'll talk about here is efavirenz. By the way, also we will talk about RNA polymerase inhibitors while we're doing those. So the first are acyclovir and ganciclovir. If you look at the structure of acyclovir and ganciclovir, they look very much like the oxyguanosine. The prodrug for acyclovir is valacyclovir. It has better bioavailability. And the prodrug for ganciclovir is valganciclovir. It also has better bioavailability. Note that ganciclovir has this hydroxyl group down, and it looks more like the oxyguanosine, so it can fool the host DNA polymerase, and hence it is more toxic. We use those for HSV, VZV, and CMV. However, ganciclovir is better for CMV. Acyclovir is not good for CMV. Acyclovir has lesser toxicity. Rarely we have CNS side effects like encephalopathy, tremor, seizures, and rarely we have renal insufficiency, especially if we use the IV form. There are several forms, by the way, and also there are creams. You probably are aware of the Zovirax cream that we put sometimes on our lips. Ganciclovir is associated with bone marrow suppression, so it's more toxic, and GI, CNS, liver, and renal toxicity. How does it work? We already agreed that it's a nucleoside analog and it inhibits viral DNA polymerase. Note the title here, it is selectivity and resistance. Selectivity, it turns out that it is more selective to the viral DNA polymerase. Resistance, one of the mechanisms of resistance of the virus to those drugs is by having a mutation in the DNA polymerase, and hence it is not fooled, if you want, by those nucleoside analogs. So what happens here, you would have binding of the ACV triphosphate to viral DNA polymerase. It competes with the oxyguanosine, and so we have incorporation of the wrong nucleoside in this case, and specifically for acyclovir, because it does not have the 3' hydroxyl group, well, this leads to freezing of the DNA polymerase. It just stops further chain growth. While for others, maybe the chain growth will continue, but definitely you would have the wrong nucleoside in this case. In this slide, also the title is selectivity and resistance. If you remember, we said that we start with a nucleoside, and then the nucleoside has to be phosphorylated 3 times to get the nucleotide. Well, it turns out that for acyclovir and ganciclovir as well, the first thymidine, the first kinase, is actually a viral one, which is kind of nice. So that means that the drug, the active drug, phosphorylated drug, is going to concentrate inside the cell that has the virus, enhance the selectivity. One mechanism of resistance is that we have a mutation in the thymidine kinase, and hence it does not activate the drug anymore. We're done with the nucleoside DNA polymerase inhibitors. Now we're going to move to the nucleoside reverse transcriptase inhibitors, the NRTIs, and those are for HIV. We have zidovudine, AZT, and abacavir. Those are the classical old one. Now we have better ones, less toxic, that we'll see in a few minutes. So AZT looks very much like the oxythymidine, and ABC looks very much like the oxyadenine. Here, the story is different than valacyclovir and ganciclovir, because really the phosphorylated form is selective for viral reverse transcriptase polymerase, and we need cellular thymidine kinase. So there's no nice specificity to the viral thymidine kinase. Therefore, the phosphorylated form can accumulate in the host cell, and that can affect the host polymerase. We have a class toxicity. The drugs that are in this class, the NRTI, all of them may lead to lactic acidosis, hepatic steatosis, and hence liver problems, and then peripheral lipoatrophy, central fat accumulation, and hyperlipidemia. You see, remember, told you that some drugs are associated with CYP interactions, and then maybe a patient may have hyperlipidemia, may need to take drugs such as statins, so that becomes problematic. Well, those are drugs that lead to hyperlipidemia, and there are others also, such as efavirenz, actually an NNRTI, and as a matter of fact, many times we can give NRTIs with NNRTI, so it makes the problem even more lipoatrophy and more hyperlipidemia with efavirenz. And in these figures, we see the fat accumulation, the buffalo hump, we see the visceral obesity, we see lipoatrophy, we see the facial fat loss, and we also see the prominence of the veins in the leg because of this fat depletion. Now, to look at specific side effects of those specific drugs, for zidovudine, it's associated with GI toxicity. We may have myelosuppression, myopathy, malaise, hyperpigmentation of oral mucosa and nail beds. You're going to see a lot of drugs associated with GI toxicity, myopathy, and malaise. And we're going to take drugs chronically and many times in combinations. So really, those are not fun drugs to take. And at the end of the PowerPoint slides, you're going to see a link, a YouTube link. I highly recommend that you watch it, and it's patients talking about the side effects that they feel with those drugs. And then what can you guess? You can guess that patients may not be compliant because of the side effects, and hence, because of that, what would you get? You would get resistance. Abacavir, similarly associated with GI toxicity, peripheral neuropathy, there's an increased risk of MI. And by the way, in some specific populations, you have to check for a polymorphism in the HLA gene because of the potential for very serious hypersensitivity reactions. Additional NRTIs, we have lamivudine and emtricitabine. Those are relatively newer than ABC and EZT, so those are well tolerated compared to the others, but of course you do have some side effects such as pancreatitis for lamivudine, and for emtricitabine you may have hyperpigmentation. And the last one, remember this one is a nucleotide analog and not a nucleoside analog, tenofovir disoproxil fumarate. It is a preferred NRTI backbone for treatment-naive patients. We're going to discuss the NRTI backbone in a few slides from now. Remember this term. Associated with little metabolic problems, basically. Remember we said we have lactic acidosis, we have hyperlipidemia, so this is a little bit less. However, it's associated also with some side effects, renal toxicity, and potential decreased bone density and osteomalacia. Next, before we move to the non-nucleoside DNA polymerase inhibitors and the non-nucleoside reverse transcriptase inhibitors, one slide on the RNA polymerase inhibitor, and the ribavirin in this case is also a nucleoside analog, but it inhibits viral RNA polymerase. It's available in several forms, and one of them is the aerosol form that we can use for the RSV, respiratory syncytial virus. It can also be given for HCV, hepatitis C virus, in combination with interferons. Side effects include hemolytic anemia, rash, pruritus meaning that patient would itch, and cough with the aerosol form. Now we move to the non-nucleoside DNA polymerase inhibitors. And for HSV, VZV, and CMV, the drug here is foscarnet. It's not a nucleoside. It is phosphonoformic acid, PFA, but it inhibits DNA polymerization. When do we use it? We really use it for TK-resistant viruses. Why? Because they do not need to be activated. So if a virus has thymidine kinase resistant, well, you cannot use the other drugs. Well, you could use foscarnet. However, it has poor pharmacokinetic properties. We have to give it IV, which is not cool, and it's also associated with renal impairment and electrolyte disturbance. So it's quite a toxic drug. We use it second line. And finally, we have the non-nucleoside reverse transcriptase inhibitors, the NNRTI. In this case, we talk about efavirenz. Remember, we mentioned efavirenz before. I told you that we may combine it with NRTI and you would have more hyperlipidemia, for example. How does it work? It is non-competitive binding of the reverse transcriptase, but there's also a very high rate of resistance, so we give it in combination therapy. Adverse effects, rash. Remember, we've seen rash so many times today. And rash is actually a common side effect that you will see in patients who are treated for HIV. We can have dizziness, headache, vivid dreams, inability to concentrate, which could be problematic. Again, CYP interactions, peripheral lipoatrophy and hyperlipidemia. We talked about that before. And on top of this, the patient may develop diabetes, which is problematic, and it is potentially teratogenic, so problem in pregnancy. We are done with the polymerase inhibitors, being a DNA polymerase, an RNA polymerase, or a reverse transcriptase. Now we're going further with our outline, and we move to raltegravir, which is an integrase strand inhibitor, INSTI. Integrase is important for HIV, for instance. It's given PO, and adverse effects, usually it is very well tolerated. Some GI side effects, some headache, and again, some myopathy. Finally, for HIV, we have inhibitors of viral maturation. You probably remember lopinavir and ritonavir. Those are HIV protease inhibitors, and if you remember with the TBL that we had together in pharmacogenetics, we give them together because they are both substrates of CYP3A4, and one of them is more of an inhibitor of CYP3A, so you'd have higher level of the next one, which is good. Of action, those are protease inhibitors. We have class toxicity, GI intolerance, diarrhea, it's probably the worst, and sometimes accidents may happen. Also, we have hyperlipidemia and glucose intolerance. Also, we have CYP interaction, and also we have fat redistribution, central fat accumulation. So you see very similar toxicities, and again, we give those drugs in combinations, as you will see in a few slides from now. This is the final class of drugs we'll talk about, inhibition of viral release. In this case, those are neuraminidase inhibitors, oseltamivir and zanamivir, and those are given for influenza A and B. Zanamivir is given as an inhaler. And adverse effects, you have nausea, vomiting, and headache with oseltamivir, and for zanamivir, because it's given as an inhaler, it might lead to nasal and throat discomfort, cough, and bronchospasm. One slide about interferons. Those are very important drugs. We give them, I believe you took them already in rheumatoid arthritis, among others, because they are immune modulators, also antiviral and also anti-cancer. As antivirus, there are several sites of action. but mainly they inhibit translation of viral proteins. They are associated with flu-like syndrome and bone marrow suppression, and we use them usually with hepatitis B and C. If you remember, we talked about ribavirin as an RNA polymerase inhibitor, and we said in combination with interferons. This slide is about HIV therapy principles. I believe you will take a session with Dr. Nisreen Rizq, who is the expert in HIV therapy. But some principles that we give combination chemotherapy. We give HAART, highly active antiretroviral therapy. We don't give just one drug. Why? Because it's more efficacious and leads to less resistance. We want to really hit early in the heart. We don't wait until the patient develops HIV/AIDS to start treatment. HIV positive, we start treatment right away. We can give many of the same mechanism of action and in combination with different drugs of different mechanism of action, so that we have different toxicity profiles and less resistance. We have what we call the triple therapy, and that is for treatment naive patients. What is triple therapy? It is a combination of 2 NRTIs with something else. Remember, we said that we have an RTI backbone. Well, so we always have 2 NRTIs in this triple therapy cocktail, if you want. It could be with an NNRTI, with a protein, with protease inhibitor, or with an integrase inhibitor. And this is not for your memory, but you've guessed so far that a patient with HIV is going to take several drugs together. So the drug companies try to combine drugs into one pill so that this improves compliance. And when you have better compliance, you have less resistance.
This slide is not for your memory. I actually updated it based on Dr. Nisreen Rizq input. Those are 3 classes of drugs that work against HIV, 3 different mechanisms. The first one is newly approved in 2022, and the other 2 are currently under investigation. This is not for your memory, it's put here for completion, but it's good that we're having more new drugs for the treatment of HIV.
I'd like you to take a few minutes to think about those matching questions. And after you think about them, here are the answers. And then this is the last slide. I highly recommend that you watch this movie. It gives you examples of side effects and people talking about the side effects from the anti-HIV therapy.